Hello friends, my name is Dr. Kazmi and you're watching my YouTube channel. So today I'm going to talk about the NICE clinical guidelines number 33, which are regarding the diagnosis and management of tuberculosis in children. So NICE stands for National Institute for Clinical Excellence, and it's an autonomous body in the United Kingdom which prepares guidelines for management of different conditions, whether that is pediatrics or whether that is adult medicine or any other subspecialty of the medicines. And most of the trusts in UK, they follow the NICE guidelines. So these guidelines are regarding pediatric tuberculosis, though the whole set of guidelines also talk about the adult tuberculosis as well. But in this particular talk, I'm going to focus only on the pediatric component of these NICE guideline number 33. So the specific part which deals with the pediatric tuberculosis actually talks about the diagnosis and management of TB in pediatrics, and it talks about this in three particular groups. So it talks about the diagnosis and management of tuberculosis in the neonates, number one. Number two category is diagnosis and management of pediatric tuberculosis in children who are 2 months or you can say 4 weeks, 4 weeks to 2 years of age. And then the third category is those children who are from 2 years to 17 years of age. So there are three categories: neonates, number two from 4 weeks onwards to 2 years, and number three from 2 years onward to 17 years. And there are discrete guidelines regarding diagnosis and management for all these three categories. So let's dive into these three groups and see what the NICE guidelines say about that. Okay, fine. So this is the guideline which you can see on the screen now. I'll just scroll down and we reach the first group, and this is the guidelines for the neonatal group. So I'll start with neonatal guidelines for the NICE guidelines. They say that a neonate, it's a child who is less than 1 month of age, 20 days of age, 28 days of age. So if that neonate has been in close contact with anybody in their home who is either a case of pulmonary or laryngeal tuberculosis, and where you know that that person hasn't had any treatment for more than 2 weeks. In other words, you are talking about those people who had less than 2 weeks of tuberculosis treatment and they had a contact with a neonate in their household. That neonate has to be assessed by a pediatrician to see if he is having any TB disease or not. So what does that mean? It means that you take into consideration all the risk factors, you have to take a detailed history, and you have to examine the child to see if he is exhibiting any features of active tuberculosis disease. So let's say if that neonate is exhibiting any signs of active disease, like for example, he is not properly gaining weight, he has got chronic cough, or he has got signs and symptoms on the which are actually pointing toward the diagnosis of tuberculosis, or on a chest x-ray you find suspicious shadow which cannot be explained by anything else. So those kids have to be investigated for active TB disease. Now, if they've got no signs of the disease, the only thing is that they have been exposed because there was a household contact. In that case, what you have to do is that you have to see whether that household contact was a smear positive case or a smear negative case. In other words, was he or is he an open case of tuberculosis or not an open case of tuberculosis? So if that person had open tuberculosis, he was diagnosed as a sputum positive TB, then that neonate, even if he is not exhibiting any signs of the disease, you have to start them on INH, isoniazid. Okay, so isoniazid has to be started and you have to give it for full 6 weeks, 1.5 months. So you start right there, and then you will give them an appointment to come back after 6 weeks where you will be doing a Montus test or TST test. So you start with INH, you call them back after 6 weeks. After 6 weeks, you give them this tuberculin testing on the skin, and then that is read within 48 to 72 hours. So if that is positive and a positive reading is greater than or equivalent to 5 millimeter, less than that is negative. So if that is positive, what you do is, again, you have to reassess whether they are showing any signs of TB disease. If there is no disease, and you know that you've already put them on INH, you have to complete the treatment for latent TBI. So you have to give full, course of the isoniazid. If the Montus test is negative, then again you have to consider them, see if they are exhibiting any signs of active disease, and at the same time you would be considering IGRA, that is the gamma interferon test, to see if they have got any some what we call as a suspicion of latent tuberculosis. So once you have done IGRA, if the IGRA is negative, then you have to stop the INH treatment and you just have to offer BCG to the child. If the interferon test is positive, it means that they have got latent TB infection, so you have to treat full course of the treatment for latent tuberculosis. So these are the guidelines for the neonatal group. So just to summarize that, neonate who has been exposed, you have to see whether that exposure comes from smear positive or smear negative. If it is smear positive, you just have to start treatment, and then you have to reassess them after 6 weeks. After 6 weeks, you will be doing TST. If TST is positive, you would see if they've got signs of disease. You will treat them as a disease. If not, you have to complete the latent TB infection treatment for the full course. If they are negative, you will be doing considering the interferon test. If interferon test is positive, you will complete the full course of latent TBI infection. If negative, you will stop the INH treatment and you will offer them the BCG. Now, in case if the smear, the index case was smear negative, in that case you don't start INH. You just you refer them to a specialist to see what they thing. So that specialist could be a TB specialist, or that could be a general pediatrician with special interest in tuberculosis. So these are the guidelines for the neonatal group. Now moving on to the other group, that is the children who are between 4 weeks and 2 years of age. Again, the definition remains the same. So if they have been exposed to an index case in their house who had less than 2 weeks of treatment, whether he had pulmonary tuberculosis or laryngeal tuberculosis or any other form of tuberculosis. So again, these children, as a doctor, you will take a detailed history and you will examine them to see if they are exhibiting any signs and symptoms of active TB disease. So if you think they've got the signs of TB disease, you will investigate further for TB, like doing chest x-ray and then making a diagnosis on based of clinical symptomatology and signs and chest x-ray findings. If they've got no signs of the disease, which happens in most of the cases here in UK, so again it's the same thing. You have to see whether the index case was smear positive or smear negative. So if there was smear positive, you start treatment for latent TB infection. If they had no signs of the disease, the child is showing no signs, then you have to refer them to specialists again, who can be a TB specialist or who can be a general pediatrician with special interest in tuberculosis. So index case positive, you start treatment for latent TB infection. But unlike the neonates, where you would call them back after 6 weeks, here at the same time when you are starting treatment, you will concurrently do a Montus test, which is the skin prick test. So you do a Montus test and you do the reading after 48 to 72 hours. So again, if that is positive, that is greater than 5 millimeter, you will reassess for TB disease, and if there is TB disease, you will treat it as a TB disease, full 6 weeks or 6 months of treatment. Initial 2 months with 4 drugs and the rest 4 months with 2 drugs. But if not, you have to complete the INH treatment, because you will start them INH and you have to complete the INH. Again, there are different regimens. I will come to that later on. If the Montus test is negative, then again you have to reassess for TB disease. If there is TB disease, well, you will treat it as that. If no signs of TB disease, you will give them the INH treatment. You will continue with that INH treatment, and you will do a second Montus test after 6 weeks. So in this age group, as in contrast to the neonates, you see there are two Montus test. In the neonates, you did it after 6 weeks of starting INH treatment. Here, you did the first one concurrently when you started them on the INH prophylaxis, and the second would be after 6 weeks of starting prophylaxis. So you repeat the Montus test again. If it is positive, you complete the INH treatment for the full course. If not, then again you would consider gamma interferon test. So if the gamma interferon test is positive, again, you have to reassess it again. Either treat it as TB disease or latent TB infection and complete the full course. If they are negative, then again you have to stop treatment and you have to offer them BCG. And why I'm saying, because in UK BCG is not routinely offered. So the thing is that if the gamma interferon test is negative, then you stop the INH and you have to give them BCG because of their past exposure to a case. So these are the guidelines for the children who are in the age bracket 4 weeks to 2 years. Now, for those children who are from 2 years onward to 17 years, again, so you would assess them for TB disease. Okay, and again, it's not necessarily that they have got contact at home. They can pick it up anywhere, because these are the kids who are usually mobile. They can go out and they can get exposure outside their homes as well. So they might have come across anybody who might be carrying tuberculosis, especially returning travelers from Africa or from South Asia or from other countries where the tuberculosis is quite endemic. So these kids who are from 2 years to 17 years, so if you think like they might be having tuberculosis, so you assess them for TB disease. And again, assessment means that you have to take a complete history where there will be certain pointers towards that direction that they might be having excuse me, they might be having tuberculosis, and then you do a complete examination as well. So you would be probably looking at whether they are gaining weight or not, whether they be having chronic cough, low grade fever, weight loss, blah blah. So again, you assess them and at the same time, while you're doing that, you would do a skin prick test. So you will be doing the tuberculin testing, and again, on the basis of that, you will see whether the test is positive or negative. So if the test is positive, the tuberculin test is positive, you will again reassess them for TB disease. So if there are signs of TB disease, you will go for smear testing of the sputum, induced sputum, gastric lavage, bronchial, blah blah. There, I'm not going to go into details of that, but anyhow, you will investigate for that. If there are no signs of the disease, you will start them on treatment for latent TB infection again, and that is the INH. There are a few newer regimens as well, like apart from INH, which can be given, but here in UK, INH is still given. If they are Montus negative, you reassess them and again repeat it after 6 weeks. Okay, and after doing 6 weeks, at the same time, you will be offering them the interferon testing as well. So if that is positive, you again reassess them for TB and either treat them as TB disease, or you just simply treat them as a latent TB infection. If they are negative, you'll stop treatment and again you will be offering them BCG. And remember, BCG just protects against the severe forms of tuberculosis, like tuberculous meningitis and miliary tuberculosis. And the effects last usually for 5 to 10 years. It does not confer lifelong immunity. So that should be kept in mind. Fine, so these are the nice guidelines regarding the diagnosis and management of tuberculosis. Now, as far as the treatment is concerned, here in UK, NICE recommends, so there are different regimens. So number one, either you use the 3 months of isoniazid and rifampicin, adding pyridoxine or vitamin B6 to the regimen. So either you give them 12 weeks treatment of INH plus rifampicin, or the other thing is you can give them 6 months of just plain INH, and to that you can add pyridoxine just to minimize the risks of peripheral neuropathy. For neonates who are less than 4 weeks of age, if there is a HIV positive or concern about interaction with the rifampicin, then obviously again INH is the preferred modality in such a scenario. Similarly, where you are expecting active tuberculosis, so it's the same. It's a 6 months of treatment. So the first 2 months are the what we call as the intensive phase, where you give the 4 drugs again: isoniazid, rifampicin, ethambutol, and pyrazinamide. And then the next 4 months would be just plain treatment with the INH and rifampicin, and after that you'll be repeating the testing to see if they have been cleared of the disease or not. So these in a nutshell are the NICE guidelines, which are known as NICE guideline number 33 regarding the diagnosis and management of tuberculosis in children. So these guidelines are quite extensive, and as I said, they talk about the definitions, they talk about the different treatment options and how to administer these TST and what are the different cutoff values. But if I go into that would take another 1 hour, probably at least 1 hour to describe all these things in details. Well, I just wanted to give you an overview like that, what the NICE guidelines say. So the NICE guidelines, as I told you again, just to summarize, so they are divided into three groups: neonatal group and infants group, where as well as the early, the toddler group. So it's from 4 weeks to 2 years of age, and then the third one is from 2 years onward to 17 years of age. So remember, in all these cases, in neonates, you have, as soon as you're suspecting that, you will be offering them TST, and then you would be reviewing them after 6 weeks. No, sorry, in neonates, you will be offering them INH, and then you'll be reviewing them with TST after 6 weeks. And then based on that, you'll be deciding. In the pediatric group, that's from 4 weeks to 2 years, and from 2 years to 17 years, you will be offering concurrently. When you're starting, you think it's latent TB infection, so you start them INH, and then you offer them TST as well. And the only thing is, once you've started them, then you have to repeat that after 6 weeks. And when you are repeating that, at the same time, you will be thinking about the gamma interferon testing as well. And if the gamma interferon testing is positive, you complete the full course of the latent TB infection treatment. If not, you just stop and you offer them BCG. So this was, in a nutshell, a quick review of the NICE guidelines regarding pediatric tuberculosis. If there are any questions, if there are any comments, you can put your question down in the comment section below, and I will get back to you and try my level best to answer that. So hope that makes you understand the current NICE guidelines regarding pediatric TB. Have a good day. Bye.